So welcome everybody. Thank you so much for attending the webinar this evening. I'm absolutely delighted to welcome Iris Knobe, a PhD student, to give us an update on the research that she's been doing. Obviously, it's an area that was of interest to lots of you because we had loads of people register for this webinar, which is fantastic. We're hoping that we'll be able to put it up onto our YouTube channel afterwards. So for those who haven't been able to attend tonight, they won't miss out. How we'll do it is I'll hand over shortly to Iris, and then we will, if you want to pop any questions into the Q&A as we go through, if you can use the Q&A box rather than the chat box, that would be really helpful, just so that they're all in one place. And then after Iris is finished, we'll go through some of the questions. We'll try and cover as many as we can. And then if there's any that we don't go through, then we can try and pick those up after the session and get back to people with the relevant answers. I think that's everything from me. Presentation's about 20-25 minutes, and then time for questions at the end. So hope everybody enjoys it, and thank you very much, Iris, for joining us.
Thank you very much for that introduction. I'll just start sharing my screen. Hopefully you'll be able to. Is that showing okay?
Yeah, that's perfect.
Great. So yes, thank you again for having me talk through my findings. So I'm Iris. I'm a PhD student at King's College London, and I'm also a trainee health psychologist. And my PhD was on predictors and correlates of symptom burden over time in patients under investigation for PoTS. It was supervised by Professor Moss Morris, Dr. Nick Gall, and Annie Jones. So, as I said, we did a series of studies on PoTS, and this is the definition of PoTS we use throughout all of the studies, so that the heart rate increase upon being upright is 30 to 40 beats per minute, along with orthostatic intolerance symptoms and without hypotension. And that's from the 2015 Heart Rhythm Society Expert Consensus Statement, which is the most commonly used set of criteria for PoTS, diagnosing PoTS. As I'm sure many of you are aware, there's quite a few issues around diagnosing and treating PoTS. So it's mostly seen in younger women with a huge range of varying symptoms. There's no real clear diagnostic test available apart from the tilt table test or the active stand test, but the heart rate increase does not always correlate with the level of symptoms. It's really poorly understood and recognized, and some of the symptoms look like the somatic symptoms of anxiety, for example, the palpitations, the breathlessness, and partly for that reason it's quite often misdiagnosed as anxiety or psychological conditions, and unfortunately diagnostic delays of several years can be quite common. It's a very disabling condition for patients, so to a similar level as COPD, and there are currently no licensed treatments available, although there are some treatments that are known to be helpful. These are not officially licensed at the moment. So the aims of my PhD, we had several. First of all, we wanted to systematically review all the existing factors and interventions, so all the existing studies that were known currently to be associated with symptom burden in PoTS. We also really wanted to understand the journey to diagnosis for patients, to see how that impacts them and how they cope with their symptoms when they don't have a diagnosis, and also how that impacts them psychologically to be dismissed and those type of things. As you'll see in a moment, there are currently no validated symptom questionnaires, and because we used a whole set of different questionnaires in participants, we had 2 symptom questionnaires and they were previously not validated. So one of the aims was to validate these 2 symptom questionnaires for people with PoTS or those with suspected PoTS. And those questionnaires also were a part of our big longitudinal study, looking at how psychosocial and medical measures are both associated with symptom severity over time. So the first study was the systematic review, where we basically looked at all the articles known at that time, which is in about 2021, that included postural tachycardia syndrome or postural orthostatic tachycardia syndrome, or PoTS, in either the title or the abstract, which is the short explanation of each study, which were about 5,000 studies and about 2,500 once I removed all the duplicates. And from that, I identified 29 eligible studies. 17 were observational, which is basically not a randomized controlled trial where they look at different factors or symptoms over time. And 12 of the studies were intervention trials. And from that evidence, we found that serum activity against adrenergic A1 receptors, reduced physical functioning, depression, and catastrophizing were all significantly associated with symptom burden in PoTS, so through correlations. There were no fully powered intervention studies to reduce symptom burden, only really small, very short-term proof of concept trials. There was one longer one where a combination of medications were trialed over 3 months, and they did show benefit to reduce symptom burden, but there was no placebo control in that study, which was one of the weaknesses. But also quite an important finding was that symptom burden was really inconsistently measured. There were about 7 questionnaires used, and none of them were officially validated for PoTS. And some of them were designed for orthostatic hypertension, some were designed for autonomic disorders. So yeah, there was quite a mix of different questionnaires used. So we did 2 interview studies, or qualitative studies, about the journey to diagnosis in the same group of patients. So we interviewed 29 people before their first appointment with the NHS PoTS clinic, and of those, we interviewed 15 people who did not have a diagnosis before the first appointment, so our baseline interviews. We interviewed them again 6 months later to see what happened in their diagnostic journey and how they managed the symptoms, basically to get a real understanding of what happened. And really the findings on baseline and 6 months follow-up were very similar, which were mainly that the diagnostic journeys were really long, they were really complex, and this huge cumulative burden for patients of treatments, investigations, all their co-occurring conditions, because people had usually quite a few comorbidities, but also being dismissed and not heard either in their sort of personal lives or medically, led to this big cumulative burden. At follow-up, we did find that the specialist appointment provided real validation and legitimization of the symptoms. It provided management. People felt heard, they felt understood, and some people described getting hope in the medical profession again. So it was a very positive appointment for almost everyone. However, the whole diagnostic process did not always fully resolve patient search for more coherence, legitimacy, or other labels. For example, they might have discovered they had other conditions that they weren't aware of, like bladder problems or reactive hypoglycemia. And although it was very useful to know, because these all have specific management strategies, it did add to their list of treatments and things to think about and treat, and that whole cumulative burden again. So the diagram here is basically from the baseline study, where it describes the symptoms, and then as a result of those symptoms, people really want to seek that physiological coherence. And you can see the small quotes there between commas in sort of italic. One lady said, "I just want to know what I'm dealing with," and really to understand what's happening to their body, what's happening to these symptoms, and how they can manage them. And if it's dangerous, they wanted to understand, especially cardiac symptoms. Then there was the individual persistence, where people really pushing themselves. There were pushing the doctors, pushing for answers, trying to figure out what's going on. If they were dismissed, they had to sort of get back up again and find another doctor that might help, but also in their personal lives, really having to push themselves to be able to continue work or the activities that were meaningful to them. And sometimes that did result in sort of detrimental effects afterwards, where that sort of boom and bust behavior happened, where they overdid it and then had payback for that later. And there's that final box, everything in your life gets set back. Really, that cumulative burden really affected a lot of all aspects of participants' lives. And the accessibility and disparities of healthcare was not really a theme, but especially in the baseline study, where people, about half had already existing tentative diagnoses, it really came up a lot about how some people had to take aeroplane flights just to get to their appointments. If you lived close, you had a better access to care. But also a lot of people talked about working in healthcare themselves and how that had been really helpful to navigate the medical system and through private, and a lot of people talked about private healthcare as well. So that's the quote there. I kind of know the medical system. I was kind of lucky that I knew how to navigate it. And that came from a healthcare worker herself. And she said without that, it would have been impossible. So the longitudinal questionnaire study was basically the main questionnaires that we administered at 2 time points. So within 1 month before their first appointment, and then again at 6 months follow-up. And there were questionnaires of symptoms. So we asked them to complete questionnaires of orthostatic symptoms, which was a five item questionnaire, but also of small fibromyalgia symptoms, because symptoms in PoTS tend to be broader than just orthostatic. So we chose those 2. We also measured distress, cardiac anxiety, which involved sort of cardiac worry and fear about heart palpitations, checking and maybe avoiding activities that bring sort of chest pain on and things like that. We measured social support and negative and positive emotional reactivity, so illness perceptions of PoTS, and cognitive behavioral responses to these symptoms. And 149 people kindly completed all those questionnaires, and 89 at 6 months follow-up. And they were mostly female with an average age of about 33. And on average, they had 3.8 co-occurring conditions, which means the common ones, such as EDS or fibromyalgia or IBS or migraines. But we also included neurodivergence and mental health diagnosis in this as well. So the common ones were anxiety, depression. There was a number with PTSD. So that's altogether 3.8. So after everyone completed their questionnaires, we checked medical records for diagnostic status. So about half of the patients had received a diagnosis of PoTS at that point. A quarter were PoTS or orthostatic intolerant, but not fully met the heart rate criteria. Just under a third were still under investigation, and 1 person received an alternative diagnosis from this group. We also compared those who actually diagnosed with PoTS with all the others who didn't have a diagnosis or an orthostatic intolerance diagnosis. And psychosocially, they were pretty much the same. But we did find, obviously, because of the tilt table test, their heart rate on tilt was higher for the people with PoTS, but also their blood pressure was lower. The orthostatic symptoms were higher, so significantly higher than the rest of the group. And they're also significantly younger. So yeah, there were some significant differences, mostly related to heart rate, which we'd expect because that's what the diagnosis is based on. Over time, the symptoms, all the psychosocial factors didn't change during those 6 months. And that might partly be due because it was done during the pandemic and there was lots of COVID related delays. So 6 months in a condition that takes several years to diagnose might not have been enough to really witness any change. The only things that had changed were cardiac avoidance and cardiac intention, which were reduced, possibly due to having an appointment with the cardiologist that might have reassured concerns about these cardiac symptoms. And damage beliefs were increased, and we don't really know why. So all these social factors collectively, defined within a cognitive behavioral model of persistent symptoms, they collectively explained about a third to half of the variance of symptom burden at baseline. At follow-up, we used the baseline psychosocial questionnaires again to see if they predicted the symptoms at follow-up as well. But because we controlled for the symptoms at baseline at follow-up, which meant that that didn't really change, which meant that the symptoms accounted for most of the variance, and therefore the psychosocial variants were not significantly predictive at follow-up. However, the medical measurements, so we took heart rate and BP measures, also from medical records with permission, they were predictive of orthostatic symptoms, not of small fibromyopathy symptoms, but at follow-up, they were predictive of orthostatic symptoms. So this is the model we were trying to test. So basically, you see the sort of causes precipitating events. So that might be a viral illness, autoimmune problems, EDS, a vaccine, causing that symptoms, the constellation of symptoms. And between brackets, you can see the abbreviations for all the questionnaires we used to measure that. So you've got the constellations of symptoms, which we measured with the orthostatic and the small fibromyopathy questionnaires. And those symptoms can lead to thoughts like, I have no control of this. This must be really dangerous because I'm really affected by it, which then can cause worry. For example, the cardiac anxiety, like these heart problems and chest pain, the palpitations, like, is this something to worry about, especially when you're new to all of this? And that again can, those sort of worries and symptoms can cause you to rest or avoid whatever brings it on. But also maybe on a day when you might be feeling better, you overdo it and then have to pay back the following day, which can then lead to thoughts of, you know, I can't do anything anymore, my life is over, I can't do anything that's meaningful. And that can really lead to depression and feelings of distress, which we measured with the distress questionnaire. And all of those things together, especially the distress, can then cause poor sleep, inflammation, endocrine responses like adrenaline responses, physiological arousal, and really in the long run, it might lead to deconditioning if you stop doing a lot of things. Also, we were interested in how social support affects this whole dealing with things. So we measured social support, and we sort of hypothesized that misdiagnosis, isolation, inability to work and socialize would not be a good thing in this whole model, whereas treatment and validation and good self-management, and really that social support might be really helpful. It's known that social support can help with self-management. So we wanted to investigate that. With the central tenet is the homeostasis. That's the sort of self-regulation that's seen in, for example, the heart rate. When you stand up, it sort of has to find a new balance. And it's the same with emotional things. It's also regulated by the autonomic nervous system. So we thought we'd check the heart rate and BP measures, the distress and personal emotional reactivity. And then the idea is, if that doesn't work correctly, which we know in PoTS it doesn't, you might have to override that with you know, your own thoughts and behaviors to try and, you know, stand up slowly, breathe, retrain your breathing, regulate it consciously rather than automatically like normally is seen in the autonomic nervous system. And that will then help with adjustment. So that was the model we tested, and our findings supported most of what we were hoping. well, not expecting to find. So all these sort of cognitive behavioral responses, the illness perceptions, the distress, were all associated with the symptom severity. What wasn't associated with symptom severity, oh, I've gone back to the previous slide, was, oh, sorry, it's doing its own thing. So the social support and emotional reactivity was not directly associated with symptoms. So, but we did find that emotional reactivity was higher, especially in those with diagnosed PoTS. It was also associated with lower systolic BP, and it was emotional reactivity was highly associated with distress, but a lot of the other psychosocial factors as well, including social support. So especially negative emotional activity might be relevant, and it was also higher in younger people. So we don't know how that works, whether that's the emotional reactivity is driven by the low BP and then amplifies all the other things. We don't know. More research is needed. So anyway, we removed that from the homeostasis box, and it's obviously its own entity. And those two factors, both social support and emotional reactivity, were highly associated with distress. And we also felt that the journey to diagnosis really helped influence whether that, how the self-management worked and how that whole symptom severity was impacted by the journey, whether it was positive or negative. So we added that in the model as well. And then, as I explained previously, there's no validated symptom questionnaire. So we assessed the orthostatic grading scale in the symptom screen for small fiber neuropathy, and found that both were valid and reliable in those with suspected PoTS. We also found that those with PoTS had the highest OGS scores, so the highest orthostatic symptom burden, whereas those with microneurography confirmed small fiber neuropathy had the highest small fiber neuropathy scores. But I have to add that those were only 5 patients, and obviously they were selected based on that they had higher symptoms without the questionnaire, but just qualitatively they stood out and were referred for microneurography testing. So there was a bias there, but it was still interesting to see. We also saw that having more co-occurring conditions was associated with higher small fiber neuropathy scores. So we don't know the direction of that relationship, whether it means if you have more symptoms that ends up in having more different diagnoses, because, for example, EDS and irritable bowel syndrome are all associated with small fiber neuropathy as well, or whether it's just if you have more of these conditions, you end up with more symptoms of small fiber neuropathy. So we don't know the direction of that relationship. We asked participants to, on a sliding scale, indicate how disabling both the sets of symptoms were, and they're about the same. So orthostatic symptoms and small fiber neuropathy symptoms were similarly disabling for patients. So in conclusion, all the studies to put together, journeys to diagnosis required a lot of energy and persistence, but they did provide some validation and positive experience, and for some people hope, but they didn't always resolve the search for more labels and understanding of symptoms. So people have so many different symptoms, and they usually were still, once they had even the PoTS diagnosis, that didn't really stop them having to discover more health problems or further diagnosis. It wasn't the end of the journey usually. We found that the OGS and the SSS can be used in patients with suspected PoTS, because obviously we didn't know if all the participants would end up with a PoTS diagnosis. So they're valid for both people with PoTS and those with suspected PoTS. Those with PoTS were significantly younger, had higher heart rate on tilt, lower BP and higher OGS scores than those without a PoTS diagnosis or orthostatic intolerance. Psychosocial factors, so cardiac anxiety, negative perceptions of PoTS, distress, and thoughts and behaviors were significantly correlated with symptoms. The higher the symptoms, the higher the psychological impact, which does make sense if you think about it. Social support and emotional reactivity had no significant correlations with symptoms, but they did with distress. And we also saw that higher distress was associated with younger age. So those who are younger are more distressed, more emotionally reactive, and they have higher symptom burden. So that's a really important thing to consider for these younger patients, that things do tend to impact them worse, which previous studies have already highlighted, but it was reassuring that ours found the same. BP and heart rate measures were significantly predictive orthostatic symptoms at follow-up. So altogether, they did predict symptoms at 6 months. And most importantly, perhaps, the better recognition of PoTS and a coordinated treatment approach, which addresses not only the BP and heart rate measures, which most of the medications tend to do, but also really to address those psychosocial factors is really important. Those are the references in case if anyone wants to look up the studies, because they're all going to be published. 3 of them already have, and 2 are still under review. And I just want to thank you and yeah, let me know what the questions are. Shall I stop sharing?
Yeah, that would be great. Thank you.
Sorry, that was very quick.
No, that was absolutely fantastic. Thank you so much for taking the time to do it. It's really great to have so many people watching, and I'm sure there will be lots of questions. Even if not today, people are very welcome to send them in afterwards, and we will more than happy to try and address them then. There's a couple of questions that we've had that are, I feel, probably better redirected to our support at potsuk.org email address, because that's managed by healthcare professionals who can sort of signpost in the right direction. So for the people who've asked those questions, if you email support@potsuk.org, and they will be able to answer your questions, because they're more about how finding a specialist and that sort of thing. We've had a question, I'm not sure if this one will be for you, whether you'd have the information, but it's, did you find that the high heart rate occurred on the tilt test with low blood pressure? Is it that the heart rate moves the blood pressure? Or is that it wasn't really within the remit of your...
It wasn't really, and also I'm not medically trained, so I couldn't comment, but we didn't correlate the well, we did, but there was not necessarily a correlation between the heart rate and the blood pressure. The correlations were mainly the younger people had higher heart rate, lower blood pressure.
Yeah.
And those would tend to be the ones that ended up with a PoTS diagnosis. If it wasn't quite so high, even supine, they were higher than those with orthostatic intolerance. So yeah, as they got, yeah, it's difficult to say exactly, but
no, I appreciate that wasn't what you were specifically,
no, but we didn't really see a correlation between the heart rate and the blood pressure. But it is hypothesized as one of the mechanisms that if the blood volume is low, then that can cause reflex tachycardia. So, but again, I'm not medically trained, so I can't really comment on that.
That's perfect, thank you. And what sort of hopes do you have for future research? Where would you like to see the next steps be?
Well, that's a really interesting question. So I'm looking to continue, but things, I think it's really important to try and maybe do a feasibility study of a more coordinated treatment. So not just addressing the hemodynamics, like the blood pressure and the heart rate, but also helping patients adjust much sooner to these symptoms, even before they have a diagnosis, because a lot of symptoms are common across PoTS and its comorbidities, like the fatigue and really addressing that earlier on and providing reassurance. And obviously everything needs to be checked to make sure it's not a more serious condition. Not that PoTS isn't serious, but it's less dangerous than perhaps other cardiac conditions. But so I think feasibility study and trials on better treatments would be really good. And it would be really interesting to look more into the small fiber neuropathy, because there is some interesting findings, especially about how having more conditions leads to higher symptoms on that. So and also immunologically, distress can really amplify all those immunological responses. So I think if there was a trial of behavioral and psychological treatments, it'd be really interesting to measure how that impacts on the inflammation, on the possible autoimmune responses, which there is some indication that that all plays a role. So yeah, really looking at the full, I think the term is psychoneuroimmunology picture, which I couldn't do in my PhD, but that'd be really interesting.
It's a mouthful, but it sounds like there's still so much to be done, isn't there? And there's still so much to be looked into, but it's really fantastic to hear what's been done so far. Somebody's asked what inspired you personally to research PoTS.
So I've got a diagnosis of PoTS, which I received 9 years ago now. But also it's such a fascinating area, and it's usually not just PoTS. It usually comes with a host of other things, and I'm just really interested how that all fits together, really trying to work out that unifying explanation of not just PoTS, but also why they tend to have IBS as well and migraines, because I feel that there must be an explanation, and I'm just really interested. Partly selfish reasons, because I've got a PoTS diagnosis, but it's also really important and overlooked. So and that, because I was training as a health psychologist and I designed my own PhD, so I got to choose the topic really. So that's how it ended up working out like that.
I think you need a passion, don't you, in order to undertake such an enormous piece of work. And I guess when it's a personal passion, it's definitely,
it helps a lot. Yes, it helps. And also, if there's not already a lot of research done, which in PoTS there isn't, especially on the sort of angle I'm looking at it, it's a lot. It's a carte blanche. You can really investigate it's not having been done before, which it's great.
Absolutely. Somebody's asking whether you found any factors in people's journey that meant that the diagnosis was more likely to be successful. So, for example, how they approached their appointments or information they shared at the appointment. And this person said that they're waiting for their cardiologist appointment, so they're just looking for some,
tips. Trying to yes, we did and we didn't. So there was no sort of personal psychological factors necessarily. We did find that a lot of people who either had medical knowledge through working in the healthcare system or had access to private healthcare, they were the group that we noticed were talking a lot more about having a diagnosis at baseline, which sort of suggests that they were quicker at getting there. We didn't correlate the sort of time to diagnosis or anything like that, but it did suggest, and also having better access geographically, so living closer to specialists, it made it a lot easier. And one thing that did come up, people were quite persistent. They had to be persistent to be heard. So I'm not suggesting bash people's doors down, but they had to, after being dismissed, they didn't give up because they felt that they weren't heard, so they moved on to the next specialist and things like that. So I guess that potentially meant, because we ended up with a group that were all quite having to be persistent. We don't know what happened to the ones that weren't persistent, and maybe they fell off by the wayside by not being referred, or that they had to had people dismissed over having a tilt table test or things like that, and they literally had to ask somebody else, can you just do it? And those were the things that really caused the delays, because there's sort of a chain of referral from
Yeah.
the GP, and then the GP didn't know what to do, so they were sort of going in this loop, being sent back to the GP and then having to go through it all again, or the specialist didn't know how to treat PoTS or didn't believe in PoTS, and then we're back to square one. So there was this loop
Yeah.
people were going through, and I think definitely people who knew how to navigate things better
Yeah.
seem to get there quicker.
Yeah, I think, I mean, everything you said really echoes in every time we speak to somebody about their PoTS journey. And if you read the stories on our website, it's very often a very, very long journey. And I think persistence is probably a trait that most people would say that they've got, because and have to have, because it's such a challenge for so many people.
Yeah,
That's really what we're desperately trying to do, to raise awareness and improve services. And one of the questions, excuse me, I'm just flicking down to see it.
sure.
Somebody said, do you know why some GPs are aware of this, like the one my daughter saw, while others have no idea? And the answer to that is there's just a lack of awareness.
Yeah,
And that is one of the real key aims of the charity, is to try and reach every GP. And we're just about to launch an early day motion. There's an early day motion that's been set up by Cat Smith MP. And we're trying to get everybody to, not everybody, we're trying to get members of parliament to sign that. So there'll be information on our website. But unfortunately, it comes down to a lack of awareness and a lack of training. But that
yeah.
is what we are trying
Well, and
to do.
just to go back to the previous question, that was actually because obviously in my PhD we set out this should be done next, and that was also, I didn't mention it, but that's also one of them, to really figure out why some healthcare professionals are just don't know about PoTS, or so reluctant to treat it even if they do know about it. And yeah, there are some hypotheses floating around about that, but it's really important, I think, to get on the same, really figure out where that's going wrong and do something about it. Yeah,
Absolutely, so much more research needed. Somebody's asked, would you ever be interested in researching medical staff's thoughts and opinions on PoTS to see if there are any factors on the medical side of late
yes,
diagnosis? So
exactly. Yes,
yeah,
that would
obviously
be,
so.
if I managed to get funding somehow for further studies, that would be definitely, that was one of the conclusions that's very much needed.
Someone's asked where they can read your PhD.
Okay, so I've got a link to, if you Google my name and find the KCL Pure page, everything that's published will go on there. So there's some of my MSc stuff, some of the other studies I worked on, but all the studies will be on there. I've also, do you want me to send you a list of the papers?
Yeah, that would
The
be
references. I mean, it's in the slides, so you can just lift it off there, but yeah, they should be online as well, because most of them are open access, so they should be on the KCL Pure page under my name.
yeah, that would be fantastic. I mean, what we'll do is everybody who's registered to the Zoom meeting, we will send an email. We'll send an email probably tomorrow or within the next week, definitely, and it can include all that information and where to find it, so people can find it nice and easily. Somebody asked if you were happy to share the slides.
I'm happy to. Shall I send that to you with because
Yeah,
the references are on there, then it makes it really
yeah,
easy. Yeah.
that would be fantastic. There have been quite a few questions that really would need to be managed by a healthcare professional, and I'm not, I'm not a healthcare professional, so I don't feel that we should cover those ones tonight. What I would say, if anybody's asked a question like that, we do have a team who are really happy. They want to answer these questions, and that email address is support@potsuk.org. So please just redirect those questions to there. And somebody will get back to you just as soon as possible, because there's some really great questions and it would be lovely to answer them, but I just don't feel that this is the right forum for it. I'm just scanning through to make sure I haven't missed anything. Somebody's put the difficulty with persistence, as we talked about, is that I've been labelled with subconscious health anxiety. How can I self-advocate against the psychologizing of potentially having POTS?
Yes, this is a really big problem, and it was tricky in my study as well, because we know this is a problem, the psychologizing of conditions such as POTS or ME, or and I don't really know what the answer is, but it's definitely a thing where you have to tread very carefully. And people were describing, you know, in their journeys to diagnosis, I don't want to be, I need to monitor these symptoms, but I don't want to be a hypochondriac. So they're constantly sort of in conflict. Do I keep checking everything, or because I need to know and it helps me manage it, because it may helps me preempt deterioration? If if my ears start ringing, I know I'm getting fatigued, so I need to stop. But yeah, there's this sort of real balance, isn't there? But not wanting to come across as a hypochondriac or health obsessed. But at the same time, you need to be, in order to learn your symptoms and to learn to manage this this whole system that's gone wrong. And you need to figure out, if everything, there's a different thing to figure out, and they can conflict, and the treatments can conflict with each other. Like, people need to drink lots of water to get their blood volume up, and then they have bladder problems, so they're going to the toilet. So it was weighing up, almost like, do I treat this or that, and figuring it all out. And that really was what that cumulative burden was partly about as well. And like, it's really difficult. And I guess I don't really know the advice, but I think sticking to people who are aware of POTS can help with some of that, because they know that you're not just exaggerating or something like that.
There just isn't a definite answer, sadly, is there?
There isn't, because you're dealing with someone who's might not want to hear about it, so they're looking for any sort of reason to yeah, it doesn't really matter what you say, they're not gonna be receptive. And it's tricky,
a real challenge. Absolutely. I think that's all of the questions that are probably sort of relevant for tonight. I really want to just stress again, I really don't want anybody whose question hasn't been answered to feel like that you've been fobbed off, or that we haven't listened to you. Please, please, please do email. You can either email me directly, and my email address is jo@potsuk.org, which is just jo@potsuk.org. Or if it's sort of it's a question that will be picked up by one of our healthcare members, healthcare professionals, it's support@potsuk.org. If you send it to me and it's not suitable, then I can obviously redirect it. But we are interested in all of your questions. Everything you ask us then shapes what we do as a charity. So please do send them through. I will keep a note of the questions as well, and if there's anything that's occurred a lot, then we'll try and do a news item on it on the website. Lots of people, Iris, have sent messages just saying thank you so much for taking the time to do it. It sounds like people have really enjoyed it, so thank you very much indeed.
No, thank you, and thanks to all the participants as well, because yeah, couldn't have done it without the whole community support. And also, if there is anything about the PhD, they're welcome to email me on the email address as well, which is on the slides anyway. So,
okay. So we'll make sure that the slides are shared with everybody that's registered for the Zoom, and we'll also we'll put them up on our website somewhere so that people watching on YouTube can access them, and the video will go up onto YouTube within the next week or so for anybody who missed any of it or would like to watch it again. So I will say thank you again, Iris, and we hope you carry on to do lots more research. We all know it's an area that needs lots more done. So thank you for what you've done so far, and we hope you'll continue.
Yes, me too. And thank you everyone for your attention and all your lovely questions as well.
Thanks everybody, and we hope to see you at another webinar soon. Thank you.
Thank you. Bye-bye.
Bye.